I have 1:30, so we'll go ahead and get started. Today is the small group session for a group of critical access hospitals that are more in the southern part of the state. And so we want to welcome everyone who's joining today. Allie Orwood from the Rural Health Association is going to help with Zoom, as she always does. We'll be recording the session today. I believe everybody on the call is a typical attender, so know Kerry Dunning, who's been working with us a couple of years now to help us build swingbed programs and improve compliance and quality of care. So we'll go ahead and get started. Kerry has information to cover today, and the presentation and some additional handouts were sent on Monday. We'll be referencing all of those in the call today, so if you could pull those up, that will be helpful too. So Kerry, I'll turn it over to you.
I appreciate it, Becky. Hello, everybody. As Becky said, we're going to cover some compliance issues and some other things that we need to be looking forward a little bit as we are, I hope, coming down to a more settled time in our pandemic year and a half here. And there is a lot going on from CMS in the last couple months. So as they come out of all the issues they had to address because of a pandemic, they're going back to some basics, and we're going to talk about those today. We're going to start first with a review that's primarily going on in the skilled nursing facilities and the rural hospital swingbed programs, your counterparts, not directly in the critical access hospital swing beds, because a lot of it they're pulling from the MDS and other supporting documentations, and you don't have to complete the MDS at this point. But what we need to draw from it really are a couple of comments that have come up. One is the importance of primary diagnosis for defining the reason and therefore the payment in a skilled facility, and we'll spend some more time on that in just a minute. One of the things that has also come out is an expectation that there should be documentation from the physician during our IDT meetings. The value of that obviously is we're meeting as a whole team. The patient and or patient representative can be in the room. Then there's an expectation, and often does happen when we come out of IDT, there are changes that can be made in meds or additional labs ordered. And I think CMS is not seeing physician documentation directly coming from those IDT discussions. In other words, the orders are getting written, but they have not been tied to IDT. So you might just review how often that's occurring and the physician input during IDT. The other comment that has come out is a consistency in documentation between nursing and therapy. There is no expectation that nursing and therapy are going to match or even come close to that. There are obviously different disciplines. It goes back probably to stressing the importance of the fact that this is skilled nursing, and nursing is a 24/7 coverage, whereas, you know, a daily coverage for therapy is considered at least 5 of the last 7 days. So it's stressing the importance of looking at a patient on a 24-hour basis, where therapy may be treating a patient at 9, 10, or 11 in the morning and writing therapy notes, exactly what they're doing, patient progress included. How are we getting the nursing notes that support?
Are you calling Frida? Okay.
How do we get the nursing notes? Got something there. How do we match up the nursing notes on a 24-hour basis as for the need that we have for therapy being involved with this patient in a skilled bed? And what that's really coming down to is to look at nursing on the 24-hour basis, particularly second shift nursing, not to put pressure on those nurses. I think they're doing their job, but often when I'm doing the chart reviews, we're not seeing much documentation that supports, again, that reason why Medicare is covering the patient. So that either may be from our from our EMRs these days, where we have so many checkboxes that we're not getting notes It may be other things. But if you look at the most need of a patient and why they're in your swing bed, it more often than not occurs at night when people are tired, they've had pain medication, and now they have to go, for instance, to the bathroom in the middle of the night. It's nursing that's having to register the fact, can they get from laying in a bed to sitting on the edge of the bed to standing to walking, and does that take assistance? And often it does. So when we look at the therapy notes where we may see something during a morning hour or afternoon hour where they're able to walk 50 or 60 feet, perhaps with just one rest period, often what's going on, at least maybe not the couple of days right before discharge, but certainly before that, where we know that nursing's having to help them out of bed. We know that they may be a one-person assist. They may have to have transfer assistance on and off a toilet. We need the documentation to support that, because that is the reason that they're still in a skilled bed. Therapy is going to make progress through the activities that they do. But the reality is, if we're sending people home that are still having difficulty, lots of difficulty at night, without support systems for them at night, that's actually the biggest reason for return to hospital within 30 days are falls. They're falls at night, and often people trying to go to the bathroom. So please look, and this is something you can self-audit pretty easily. You just take one day somewhere in the middle of the stay and see what the therapy notes say. And if they say they're walking 100 feet with a rest period, and you look at the nursing notes from the overnight, and that person's a one-person assist, then we need to have discussions in the IDT meeting, let alone in morning meeting, about how safe are they to go home and what does that mean? How long can we keep them, and what do we need to be training on, and how do we need to involve the family or others that will be their support system when they get home? One of the other things that's going on are CERT reviews. The CERT in this case is a comprehensive error rate testing. CMS contracted with them a couple of years ago really to look at factual information only. In this case, they are looking for proof that the skilled service could only be provided in a skilled nursing facility or swing bed. This goes back to original language and regulation that says that's the proof in the pudding. Could they have gone to home health? Could they have gone to outpatient? Why do they need to be an inpatient? Why they need to be a head in the bed? And so CERT was tasked over a year ago to review this, and they started in 2019. I suspect they'll move into 2020, but what they're looking for is proof. That can come from your practical matter note, that can come from your physician certification, it certainly comes from your documentation as to why this person can't be at home yet. So back to documentation one more time. This CERT review has led to another CERT, which is the physician certification and recertification, and they are reviewing that in conjunction with this comprehensive error rate testing survey going on. And right now they're looking prior to the pandemic, they're still in 2019. But you remember the physician certification is the physician certifying that they need to be inpatient, they need to be head in the bed. And it's based on the problems ICD-10 treatment lists that we have, both on the original certification and then in any recertification. So it's very important that you are looking at the reason they came into your swing bed program, and then what's keeping them in your swing bed program, and making sure that documentation is there to support it. But anytime they're looking at a physician cert or recert for this kind of review means they can find physician certification issues. So remember, anyone staying longer than 14 days needs a recertification. You need to make sure it's there before you close a chart, and you need to make sure 4 questions are answered. One is that list of ICD-10's problems, treatments. It may have changed slightly, but it still goes back to the original problem list. Second question has to do with the expected length of stay in your skilled program. In other words, do you expect them to stay another week or 2 weeks? It is an estimate, and that's fine. The third one is related to the discharge disposition. Again, an estimate. But if most of your patients are leaving your program and going to home health, then that is something you can put in there, that's at least an area that you're going to look at. Fourth question is one that gets left off a lot, but it is it still related to the qualifying 3-day hospital stay? I know during waivers, you may not be using the 3-day acute stay rule, and you would still have to kind of circle or put a mark on that says, you use the PHE waiver instead of requiring the 3-day hospital stay. If any of that's not filled out in total, they can take back all your money for that stay, or certainly for the days that certification covered. So please make sure you're reviewing the certs, because you should be anyway right now, but it's getting caught up in this comprehensive error rate testing also. Infection prevention and infection control, as you can imagine, during the pandemic went to the top of the list for reviews. CMS started last summer reviewing skilled nursing facilities and swing bed programs. They also were reviewing acute at the same time. So if, for instance, a critical access hospital, they'd probably be looking at your acute and your swing bed for the documentation of what was done for infection prevention, infection control. They can ask for additional information. The last time your staff was trained, can look at your training programs, can look at your policies. The reason I'm bringing this up now is I have a facility, a critical access hospital in a Midwest state, that about a month ago got a letter from CMS saying they were being fined. They had started a separate unit and opened some beds up to take patients that were still in acute beds, but were going to have to stay there 2 and 3 months so that they could use the main beds that they had in place already for turning over for new patients. So they set it up very carefully, basically did everything absolutely the way they should have done it. They had the same nursing staff rotating through that. They had 3 patients at the time. Same with respiratory therapy. They didn't let dietary on the floor. Nurses were getting the food at the doorway. They didn't let housekeeping in. They had nurses doing housekeeping with nurses agreeing to that, because remember, we're not turning over rooms. We're taking care of the same patient. Everything was the way it should be and documented. They got fined on the fact that CMS could not find any proof that the nurses had been trained in housekeeping, prevention control, and infection prevention. And it was a $15,000 fine. It wasn't a slap on the hand. That's a pretty substantial fine. So they are taking it to a hearing. I don't know where they're going to end up with that, but it is a heads up that they're very serious about doing these reviews. And I'm going to tell you, I expect to see more towards the end of the year, and I expect to see a lot of surveys, both state and federal surveys and financial audits in the beginning of 2022, because at that point, CMS has got to go back to Congress and defend how they distributed the money. And the way they normally do that is start ticking up the reviews. So please look at infection prevention and control one more time. Make sure everybody on your team has had recent training, whatever you want to define that as, that there's proof of that training, and that your policies are up to date with what you're doing. The OIG, which is the Office of Inspector General, I call them the FBI for healthcare. They're the ones that do the investigation part of it. There is a current review going on. They expect for this review to end and there be a report at the end of 2021. They are looking at payment for critical access swing beds from 2015 through 2019. If you do the math, that's a 5-year period. I'm going to suggest you do your own review. I think it would help you be heads up to be able to explain both to internally and certainly to an audit team and certainly to the press if it comes to that point, why we probably had changes in payment. If you remember 2015 at all, if you've been around at all, 2015, we were doing over 90%, probably over 95% of our admissions to swing beds were short-term rehab patients. Short-term rehab patients were staying 5 days, 7 days, 10 days, 11 days. They do not require, they don't cost as much as our clinically complex patients because they don't require as many meds and supplies usually. So when you take a short stay with a rehab patient, that's a less expensive patient. And you compare that to 2018 and certainly 2019, where we had moved into the clinically complex world. And a lot of what we were taking at that point were 30-day antibiotics. So people were staying 23 and 24 days as they finished up their antibiotic. They had more costs. Some of those antibiotics were pretty expensive. And as you know, if they're on 30-day, they were getting multiple antibiotic medications. So I think you'll be able internally to see there was a shift in the type of patient, both by length of stay and by complexity of that patient and by cost of that patient. And what I would tie it to is maybe your top 5 admitting diagnoses during each of those years, so that you can really show that probably in 2015 you had some of the R codes, the patients that were the rehab patients, they were weakness patients, gait disturbance type patients. And if you look at 2019, we had moved into more clinically complex. Even if it's a 40-60 split with rehab being a 60, there's more cost in that 40%, but I think you may find it's a higher percentage than that. But you need to be prepared for this and talk it through internally with your financial side of your house. The other thing that has come out with from the OIG and CMS agrees with is the use of home meds. And the discussion here is that Part D pays for those medications, and people have to pay for Part D separately from their Part A and Part B benefits. So in this case, it was a matter of when you are in a swing bed, a critical access swing bed, anything provided to that patient is supposed to be billed on that Part A claim coming out of the swing bed. So those are supposed to be meds that you are providing that patient. The second part of it is where the OIG just said it was double dipping. In other words, if you use Part D meds during Part A stay, when that patient goes home, they have to reorder Part D meds sooner because they should have been Medicare should have been paying for it under the Part A stay, and that means the Part D meds would have still been in place for a 30-day period, for instance, in total. And so one of the questions that we've raised with it, and I haven't heard an answer yet, is we are increasingly getting patients coming to a skilled setting, swing bed setting, that have a med that may not be in your hospital formulary. And the issue is, how do we admit them, and how are we going to deal with this comment from the OIG and CMS? And I don't know yet. I will tell you the straightforward answer is there is a long-standing regulation that says if you cannot care for the patient, you shouldn't admit them. Having said that, that's not going to benefit CMS at all. If we slow up people leaving acute to get them to a swing bed because of a med, that's more costly to CMS. On the other side, does that mean they'll give us 24 hours or so to get that med in-house? I don't know what the answer is. I have no idea. And this is one case where I really don't want to take a risk and say that I can think like CMS, because that thought actually scares me at times, that I'm beginning to think like them. So just watch for your max and we'll be paying attention. Becky will be paying attention to it at a state level. I'll certainly be paying attention to it to see if we have any changes in that definition. And the next one is a discharge rule. Yes.
Can I interrupt you for a minute? I had a request come to me before you got much farther. You had made reference to R codes. Can you explain what R codes are in more detail?
Yeah, absolutely. And sorry to use the language. I do get caught up every once in a while using the familiar language and forget that not everybody has to live in that world. R codes are the ICD-10s that fall under R. They typically are the rehab. They are gait disturbance. They are weakness types of patients. There are other R codes there. It would be the same thing for using a ICD-10 code for diabetic patients would be another letter of the alphabet. So that's where they're coming from. And we use them we used them a lot as an admitting code, and we're not allowed to use them anymore. On the PPS side, the swing-bed programs that are in rural hospitals and all the nursing homes cannot use them as a primary code anymore. They can still be used as therapy treatment codes, but they cannot be used as the primary reason to admit someone. And CMS actually made a comment that I agree with, which is if we look at the weakness, and we had an awful lot of our codes going through Swingbed that were weakness patients because they were post-surgery or they were post-orthopedic type patients. Medicare said, look, we know they're weak. We don't need that as the primary code. What we need as the primary code is why they are weak. You know, was it because of surgery? Was it because of this or that? Same thing with a gait disturbance. We don't need to know that their gait's not in sync with the way it should be. We need to know what caused that gait disturbance, because obviously it can be orthopedic, neurologic, and so forth. So that's why they are saying we should not use that as a primary admitting diagnosis. But again, I'll repeat, therapy can use them as treatment codes. So if you go and look at ICD-10s, you will see all sorts of letters of the alphabet cover certain types of, I think we're at 67,000 ICD-10 codes that we use in this country. Does that help, Becky?
Yes, yes. I think that explains it well.
All right, and then the discharge, we were supposed to be involving the ombudsman all these years in skilled. The nursing homes have done it. I'm not sure the language got out as far to our swing-bed programs, but CMS is saying you are under a skilled level and we need to be following the federal regulations. So I'm going to let Becky take this section because she actually did some homework for you and got some information for you in the state of Indiana.
Yes, I was able to connect with the director and deputy director for the ombudsman, and it was a very good meeting. In some areas of the state, some of the ombudsmen weren't real clear on the role of the swing bed, and so some different individuals across the state were receiving some different direction. So I was able to do some education with the ombudsman group. And in the email that I distributed on Monday with the presentation for today, there were some additional handouts. There was a letter from the ombudsman group that it very clearly outlines when the ombudsman needs to be notified. They said that they often receive the question, do the notices of non-coverage be sent to the ombudsman? And they do not need those notices of non-coverage. So you can mark that off your list. They did provide algorithm that they use in Minnesota, and they've kind of adopted it here in Indiana that you can follow that will give you some direction on if you have a atypical circumstance, you can follow the algorithm and it will indicate to you whether you should notify the ombudsman or not too. So they also said the question had come up regarding visiting on site, and they are to have access on a quarterly basis to come in, visit with swing bed patients, and be able to address any quality of care concerns that they receive. So definitely download that letter, read through it. I think it, again, does a very nice job of kind of outlining when they should be notified. And so hopefully we've been able to clear up some of the confusion around the role of the swing bed for some of the ombudsmen in the state. And I think some areas growing their programs this past year has kind of led to more questions, and we just needed to kind of shore up that process for everyone. So if you run into issues, let me know again, and I will follow up. They were very appreciative of us reaching out and touching base. So hopefully we've been able to kind of resolve some of the issues that you've been having and making sure you're following the process to notify the ombudsman correctly. Thanks, Kerry.
Thank you. And so I'd also like to remind you guys that an ombudsman can help your program. If you have a patient that doesn't want to be discharged, if you have a family that's not happy with the discharge plans, other things that come up during the stay, you have an equal right to call in the ombudsman. They are the patient representative. That's why this program was started. But when facilities are having programs, and I have found in the last couple of years as we've gotten families that they're getting a little, well, they're not quite belligerent, but they're getting stronger in their feelings. about discharges that it's been very, very helpful to involve the ombudsman. It gives you an outside source to help mediate and document. So just remember they can work in your favor also. All right, one of the things that we've been talking about over the last couple of years, I've heard Becky talk about at different points in this, is the State Operations Manual. It really is the one that takes thousands of pages of regulations and ties it down to specific things that we have to be doing, reviewing, paying attention to. In the last 3 years, they have revised different sections, including discharge planning, infection control, emergency preparedness, and the swing bed sections. I would say all 4 of those areas are in heightened alert for surveyors and auditors. Certainly this last year and a half now, with infection control and emergency preparedness have gone to the top of the list. So there are 2 sections that you need to look at and review as a team. One is Appendix W. That is the section of the State Operations Manual specific to critical access hospitals. Within Appendix W, you will find the language for swing beds. And I can tell you, if you just pull up State Operations Manual or State Operations Manual Appendix W, Google type search engines do a very good job pulling it straight up for you. And the second section I do not have written there, probably should have written, is Appendix PP. P is in Paul, but PP. It is for the surveyors. It's actually called the Guidance to Surveyors. It literally lists the questions and the topics surveyors should cover when they are on a survey in your facility. And I mean, literally, it'll list out the questions. It also lists out the severeness of whatever the issue is, from a simpler fine or problem into something that they found was including all of your swing bed patients, and the fines can be substantial at that point. So it's a good section for you to look at. All 4 of these sections are probably things that your team needs to at least read through, and if they're discussion points, have a team meeting on it. Infection control and prevention obviously has been heightened for everything in the hospital. Where I find some issues sometimes is the emergency preparedness plan in a rural hospital is geared for acute and doesn't really address this post-acute swing bed setting. For instance, transfer rules. In reality, we should have a transfer rule with another level of care, another post-acute setting in case we, I don't want to wish anything on people, but certainly I have Oklahoma clients that have had to abandon a hospital because of a tornado's done damage to part of the hospital. They've had to transfer their swing bed patients, either release them to home or to a nursing home or to another hospital with swing beds in that immediate area. So you need to have people looking through that, making sure all of that is up to date. The other thing I put in here to remind myself to tell you is the physician certification language, the regulatory language on that is in the billing manuals and not in the State Operations Manual. Your financial people will know exactly which manual to pull up, but just know that there are very specific rules for physician certification in case you're reviewing that. The other piece is in the discharge planning. We've had some difficulties. It goes back to, going back to the original plan of care when we're bringing somebody in, and with that 48-hour baseline plan, we are addressing our discharge plan. We do need to include, it says resident there on that list because we're under long-term care regulations and skilled nursing regulations. We do need to have proof that the patient and family of that patient or patient representative have been involved, and that it was developed with the patient in mind as to where he or she may want to be discharged to, particularly if we're beginning to talk about going to a nursing home or going to assisted living other than back to their home. So those regulations you can find in the State Operations Manual if you want to see the language and requirements for that. Brand new in our language pattern, because I've only known about this for 4 to 6 weeks maybe, is something they're calling clinical plagiarism. CMS has been reviewing notes, and this actually started with providers and not us. And it came from their interest was piqued by a 2017 study that found only 15% of the provider progress notes were entered manually. The rest of it was cut and paste. So they have sent warnings to the providers about the lack of original information in the record, which means if they've sent warnings, they're getting ready to review that pretty heavily. So let me give you an example. In your Swingbed program, if you have a hospitalist or a specialist or another physician that comes and sees Mrs. Smith on Tuesday and Friday, for instance, of a week, then they take, if a provider takes the Tuesday note and just cuts and pastes and makes it the Friday note, that's the cut and paste that has nothing new in that note is what they're interested in. Remember, providers in particular are more directly related to a billing based on a progress note, on a visit. Their E&M codes have very specific times, information that's supposed to be included for them to be able to bill. So whether the hospital is billing for them or they're in their own practice and they're billing for them, they are actually getting money tied to visits in Swingbed and other settings. So that's one interest. The plagiarism piece of it comes from the fact that CMS has found times, that's the imported part of it. And I have not seen this, but I'm obviously going to be looking more closely now, where let's say a doctor's also seen Mr. Jones. So he takes Mrs. Smith's note on Tuesday and copies and pastes it directly into Mr. Jones' chart. If you notice, I just changed genders, let alone patients. So cutting and pasting that, that's the plagiarism. They do not want to see that at all. On top of it, they do want to see some kind of individual-based and at that time of day, on that date, documentation. So if they cut and paste the basic information that hasn't changed on the patient and then add to that progress note the information particular to what they noticed in that day, what they ordered in that day, or anything else they might be doing, that will get you out of this upcoming, I think, review that they're going to be doing. So I would be talking with your providers. Having said that, I'd be looking at our own documentation in all of our disciplines to make sure that we're not seeing the same note over and over and over. It goes back to the difference of the patient in nursing during daylight hours and nighttime hours, for instance. Even in nighttime documentation or day documentation, things change during the day and change during the night. And so there shouldn't be just a note that's repeated over and over and over. Doesn't mean you can't, again, cut and paste basics, but it should be something to that specific time when you're looking at the patient. So I would be reviewing notes right now because this has just picked up steam, as I said, in the last month or 6 weeks that I've heard it discussed in different forms. So pay attention to it, please. The big discussion going on across the country is about our IDT, or interdisciplinary team notes. Medicare from the very beginning says basically everyone's had to be in the room. And I have room in quotes there because from the very beginning, CMS has said that the physician could be, well, it says if the physician can't be in that meeting that day, so it's not meant to be forever, they can connect telephonically. I love that word. I haven't heard it since, I don't know, what, the 1950s or something, but that means now we can connect by telephone Zoom. Certainly during the 2020, we had a lot of IDT meetings where we were connecting people by Zoom because we didn't want patients out of their room. We didn't want different disciplines necessarily all in the same room. So it depended on how you were doing it, but the expectation is that an IDT meeting will occur where there is discussion with everyone in the room. So there, the physician's getting to hear the professional statements from all the disciplines in the room, the patient, and I think this is one reason this is honestly picked up steam for review, is the patient and or patient representative is supposed to be in the IDT meeting. They should be able to hear what the different disciplines are saying and how they're coming to the conclusion on, how long you're going to stay, or what the medicine changes are going to be, or what treatment's going to be, etc. So first of all, I would check your IDT notes and make sure that it clearly shows who's in the room. And remember, there are two regulations. One is that the patient and patient representative should be approving that care plan is representing their goals for their swing bed stay and their discharge plan. So one of them says that they should be involved in approving that. And later in the regs, it says they should be given the opportunity to sign off on that IDT note and or care plan, however you're working that, or both if necessary. So I don't know, it's not required. I'd almost be recommending that you get a signature from the patient or their representative or family member, because I don't know how you prove that later on audit. And you really want that patient, and if they have disagreement, that's been documented in those notes too. So please make sure that you are looking at who's in the room, who may not be in the room at this time, and how we're going to get them involved in the IDT meeting. And on earlier calls, Becky has raised the issue, or somebody, I think, actually from a facility raised the issue about the difficulty of getting dietary and nutritional services in the room at the time of IDT because of the time consumption. There's still a required person to be involved. They were added, I think, in 2018, along with aides or CNAs as a required part of the team. So how do we involve them? What time are we having these meetings? I think that's an internal discussion, but do know that they are supposed to be directly involved in these discussions. That has picked up steam because we've got an aging population. We've got an aging population with more comorbidities, and they're going to have, we're seeing just a huge increase in swallowing difficulties. So it's going to be a component that's real important to this team, and you're going to have to see internally how you can make all those arrangements. I always recommend that we should be doing some ongoing training, and since we're talking about documentation a lot today, if you notice those warnings from CMS, I think you should be using the Swingbed version of the MDS as a training tool. There are 16,000 nursing homes and there's 1,600 rural hospitals that have to complete an MDS. Only the critical access swingbed programs do not have to use it. But CMS spent years and years and years developing the MDS, actually in the late 1990s, I think. And this is where they show what they want to have in documentation. They have an accompanying RAI manual, a resident assessment instrument manual. It's available online. In fact, you can Google it or use another search engine and get to the RAI manual easily. Don't download it. It's really over 1,100 pages long. But I'm going to suggest perhaps if you want to start as a training tool, one of the sections that's good is Section I, and you could get the Section I information from the REI manual and use it for your discussions. The value of the REI manual is it tells you what requirements they have. So for instance, when we're looking here at 13 primary medical condition codes or categories, I think they call them, behind each one of those 13 is a list of types of diagnoses that fit into those categories. I think if you review the REI manual and look at what's behind each of them, you may actually see other types of patients you could be admitting to your swing bed, particularly if you're trying to grow your program at, or particularly if you have a certain kind of patient that's prevalent in your community. And the better part of when you have the REI manual is they give examples. They give examples of the kinds of patients. They give examples of the documentation they expect. It is a great way to train your program. So I always use the example right now. I probably need to switch to another category, but I've got it in my brain at this point. The non-traumatic spinal cord dysfunction includes arthritis patients, includes spinal cord infections. So there are a lot of things that we may be limiting ourselves a little bit on the types of admitting criteria that we have for our program. I'm going to tell you this is affectionately called the 20B question. You see where, if you hear about 20B, for those that have to complete the MDS, over 90%, somewhere upwards usually of 95% of the payment to one of the PPS settings for skilled nursing comes from this one line right here, and that's the primary ICD-10 code. As you can see by the length, there's room in there for a dot and then the qualifying one or two numbers or letters after that. What this should say to you is what you select as your primary diagnosis is equally important. It is the defense for why you put them in your critical access hospital swing bed program. So even though you do not have to put it on an MDS, you are putting it on your claim, and it goes in that principal code, primary code area on a claim. And that means it's very easy for CMS and your RAC audits, your all sorts of audits can come. All they have to do is look at your claim, and whatever is in that primary code is what they're going to use to defend. You're going to be defending why you admitted them, their length of stay, the kinds of services you provided. So I would be reviewing your own ICD-10 primary codes, which is often when you're around me, I'm asking, what are your top 5 admitting codes, and are you looking at them, and do you look through your documentation to see that it supports that primary code? It's very easy for us to get diversified and look at a number of conditions with patients these days because of the comorbidities. But your primary code that goes on the claim, if for the PPS ones, their primary code that goes in this 20B question is defining to Medicare what they're going to review. So I would suggest you do it before others do. This list I got in the last month or so. It's a list from the middle of 2019 through the middle of 2020 of swing bed admissions. You will see from this list, if we looked at it 5 years ago, we would have seen a ton of orthopedic things on here. We still do have major joint. We do have somewhere over here, somewhere there's another, some amputation. There are still what we would call therapy or rehab type patients. What has picked up, you can see that this was into the 2020 years because we did not have vent patients on this list at all prior to the COVID issues coming up. But you see sepsis is on here. There's other infections. I think we have a lot of C. diff in this country. I can tell you in the state of Florida, we have TB again as a diagnosis that is growing quickly across our state. So I would look again at this list and see if there are types of patients you could be admitting or you are admitting. This is going to take different types of documentation support than our short-term rehab patients. So it should remind you again of the things that we need to be documenting. So we can have obviously skin breakdown with our infections. We can have skin breakdowns. Here's a hip and femur procedure. So it's a lot of areas, and we need to make sure that we are, one, documenting why that person's in a bed and not in home health and outpatient. And number two, I think it's an opportunity for you to look for ways you can grow your programs as you come out of this primarily COVID and versus non-COVID type of admissions we've been doing. So having said that, we're at a point where we're beginning to look at the end of the public health emergency, what they call a PHE. It's not going to happen in the next day or two. And I will tell you, they have to give us 60 days notice before they end it. So it shouldn't come up and surprise us too much. But we need to start looking at what this has done. Some of you have used the waivers. So if you've used the 3-day waiver, for instance, and your physicians have gotten used to that, we don't want to wait till 60 days before to start changing their practice patterns. Again, where they've been able to admit from home, admit from ED, admit from observation. We want to make sure they understand what rules are staying, which are going away. I'm pretty sure we're going to have telehealth and telemedicine, but it won't be all the codes that we've been able to use during the PHE, so we're going to have some education there. So one, we need to know what we learned about our hospital. We need to know what we learned about our community. Many of us learned a lot very quickly and very painfully, honestly, as we just kind of got thrown into it. But we had programs that stepped right up and took vent patients in our swing beds and took more critically ill patients. That is the one thing that CMS has noticed that's in our favor with swing beds, is the nursing homes had to shut their doors either because they had COVID or they didn't want COVID. Then the CMS was still looking for a way to get people out of ICU, out of acute beds, and the swing beds across the country really picked up a lot of that gap. So that's a positive for longevity in the swing bed program. But you need to see what we learned, and we are going to have to be more flexible. Simply put, since 2000, the United States has had an epidemic or pandemic every single year. Pandemic meaning multiple countries were impacted by it. Just before COVID hit, the year before, we had 63,000 deaths in this country from flu. It just was a blip on our radar. We've had SARS. We've had all sorts of versions of things since 2000. So we are in a time period where epidemic, pandemic are going to be part of our language. So what is how are we going to flex with that? What kinds of patients are we willing to admit? Can we admit other kinds of patients with training? And then I think the most important part is starting to think about a reentry plan. If this comes at the end of the year, which is some of the thought process right now, that we're going to go back to the pre-pandemic rules with a few additions and changes, we've got to start telling everybody this is going away probably by this month, and here's what we're going to have to do that we were not doing in the past. As far as flexibility, one of the big things that I started talking about in the last couple of years, I think we're going to center in on a lot of discussions, is how we build a community around our healthcare services. And we can do that easier in a rural setting than some of our other settings. And what I mean by that is we can't keep people in swing beds forever. So how we build relationships with home health. For instance, I've got some programs already working with home health. When I ask you or suggest to you that you should be tracking readmissions up to 30 days after they've left your swing bed program, some of our programs went to the home health agencies and said, hey, we should know if somebody's going back to our ED. We should know if somebody's going back in the hospital. Can you call us when your home health patient is being discharged or going to ED? To one of these settings. So we're beginning to involve other healthcare facilities and entities in that discussion. More important, we found during this that people needed transportation, people needed food. We had to have all sorts of things. We have programs across the country. Iowa was one of the good programs that started transportation vouchers. Well, they had them. They expanded their transportation vouchers. Florida had utility payment programs. We're going to have to build out a community, and we're going to have to be ready to take care of our aging population. And what does that mean, not only in a healthcare setting, but surrounding a healthcare setting? So part of our reentry is going to be planning. It's going to be looking at, okay, here's what we can do in our swing bed. Here's what our acute can do. Here's our outpatient services. Here are our partners in our community. That may be geropsych, maybe a rural health clinic. How do we coordinate services for people? And then how do we get transportation? I know at a national level, one of the things, and I have not read it yet, on the safe harbor rule changes, transportation is in that. So I suspect, Becky, somewhere in the next couple of weeks, I'll stop long enough to try and look at that more carefully and see how that will help us arrange for transportation for people, leaving swing bed, having to get back for outpatient services and so forth. So this is the time for you as you settle back into a different, but maybe less hectic routine than you were in 6 months ago, that we need to have some planning and talking about partners. And one of the things, I haven't even talked to Becky about this yet, but one of the things I want to do is try and bring examples from different parts of the country where people have done some things that are very creative. Doesn't mean you have to do all of them, but maybe if you hear the ideas, you'll hear something that will help your community and help your hospital. So changes that we need to consider. I've got plenty of people working for large non-healthcare businesses that don't expect to be going back to work every day. They expect to be working remotely. I have a healthcare clinic here in this town where a lot of their staff is working remotely if they're not, in the direct care of seeing patients. So we're going to have some changes in that and changes in our teamwork definitions, management styles. We're still going to have to go back to the problems we had before a pandemic, which is we were headed to major staffing shortages, particularly in nursing. So we're going to have to deal with all this. So we're going to start developing a plan. I'm sure your team is already talking about it. Your leadership is. So I'm sharing this. This is a planning project layout that I really like because it's short and sweet. The things in the blue are what the facility is going to do. The things that are in the smaller print are what we expected to happen with payment from CMS, but also other payers, where we expected the post-acute discharges to occur and changes. We wrote this in 2016 and we're in 2021 and we are actually on target. We have additional space being built. It's a cool project. They're building 16 apartments. And it ended up not being just for senior housing. There was a need in this community for parents of adult disabled children to be able to have a place near a healthcare facility. So they're building out that with the idea that as the parents pass, that the adult disabled child can stay in that apartment and have support services. So it's very creative. They started aging in place things. So here's some ideas of things that you can look at going down the pike, how to use healthcare as a basis for community development of projects and some ideas for future services. All of this said, there's been plenty here. Some is going to be CMS driven. A lot of it is going to be dependent on where we want our swing bed programs, where we want our hospital services to grow. Now that we can maybe start taking a breath and say, here's what we found out about ourselves. Here's what our community needed. Here's what we can do. I've got swing bed programs that are taking admissions from 3 and 4 states now because of the way they were able to do some unique things during the pandemic. So I think our radius is expanding. It doesn't have to just be your county and maybe a next door neighbor county. You just have to decide what you're going to specialize in. So I'm going to suggest you start thinking ahead a little bit. And I've included some tools here that you can access. I've included the internet address for them if it was needed. The rest can be pulled up by that name there. But there's forms and there's core elements. There's preventable readmissions information from New York State. New York State does a lot of really good information. And by the way, that guide has not changed since 2013, but it's still very viable. So hopefully this will help everybody kind of take a deep breath, look at what the next step might be for your individual facility. And I would be glad to try and answer questions now. And you guys and Becky know how to find me if you need me to answer questions some other day. Becky?
Kerry, one thing that you might mention is some of our hospitals do have cardiac rehab and pulmonary rehab programs, and the question has come up regarding providing those services in the swing bed area and appropriate billing. So if you could maybe address what your research is.
Yeah, I am checking with CMS on how they want to handle it. We certainly can offer cardiac and pulmonary rehab. I mean, those types of patients we're seeing. It's the reimbursement I'm not concerned. I'm worried about. We are supposed to put everything that on the claim. You know, we've had talk about dialysis, that if you have an outside dialysis center, that they have to bill the swing bed program if you're sending somebody out to that. I think it'll be the same answer for cardiac and pulmonary rehab, that they would bill their services to the swing bed, and then that would be on the swing bed claim, but I have no proof of that yet. I did query CMS. I was getting very, very quick answers from CMS about 4 or 5 months ago. They've slowed up. I suspect they're getting lots of queries right now, and they do have limited staff. So that has been out, gosh, I don't know, 2 or 3 weeks maybe, Becky, because we had this discussion somewhere in that range. But anyway, there is a query out there. I know the services can be provided. It's whether it can have a separate charge or not that I need to clarify, and how they want that billed.
Thanks, Kerry.
Mm-hmm.
So you can chat questions in, but definitely feel free to unmute and ask any questions. That, I think, covered some of the issues that even Kerry addressed, issues that have come up on other small group calls. So I'll just pause for a minute and see if anybody has anything additional today. Kerry, I don't see anything else coming in, and so definitely if you run into issues or unusual circumstances come up, let us know. We try very hard to get back very accurate answers. If you ever receive different guidance than what we provided, we want to hear that too. So hopefully the information today was helpful. Kerry really gave us a lot of good information to be on our toes about and be prepared for. So we want everyone just to have a wonderful afternoon. Stay safe. And thanks to Allie for supporting Zoom today. And thanks to Kerry for all of her great information. So have a wonderful day, everyone.